quality of work life. Thankfully, many new beneficial therapies are available. Our expert speaker today is Dr. Stephen Kosa, a neurologist with Meritas Health Neurology. He'll give us an update on new therapies and discuss the benefits of a headache specialty care clinic. Dr. Kosa earned his medical degree from the University of Kansas School of Medicine, where he was also a resident in internal medicine. He then was a resident in neurology at the Mayo Clinic School of Graduate Medical Education. He's board certified in neurology, holds a certificate in added qualification in headache medicine, and is a diplomat in headache medicine. Dr. Kosa joined Meritas Health Neurology in 2014, also is North Kansas City Hospital's Stroke Center Medical Director. If you have questions about migraines, please submit your questions using the Q&A feature below. We will get to those at the end. Please join me in welcoming Dr. Kosa.
Thank you, Dr. Righteous, and thanks to everyone joining online to learn more about migraine and our newly opened headache center. So today we'll discuss migraine and the new treatments that are available. There's been a lot of development in this field. It's very encouraging. There's even more to come, so more to that later. So I'm going to introduce the Meritas Health Headache Clinic, and then we'll take your questions at the end. So what is migraine? So typically it's on one side, so it's a pulsing or throbbing pain. Usually it's moderate or severe in intensity. So patients aren't going to be out doing activities. They typically want to retreat to a dark and quiet environment to get away from stimulus. A lot of times there'll be nausea or vomiting with it. They're sensitive to sound, to light. And to get the diagnosis, you need to have at least 5 of these attacks. Patients with migraine can have other types of headaches too, but this is, to get the diagnosis, we need these kind of features of the attack. So we know that it causes a lot of disability. So and one of those reasons is it hits us during our most productive years of life. So there's a peak in the 20s up to the 40s, which then thankfully starts to go down as people age. So people live with a lot of years of disability with migraines, second only to lower back pain. So patients with migraine lose out on lots of activities, so they're not going to those sporting events of their kids or other events they may want to attend. They may not go to a wedding, for instance, because they're afraid they're going to have a migraine. So a lot of people are going to, stop activities that they'd otherwise want to participate in. So what do we do for treatment? So there's a lot of old generation treatments that they were helpful, but they left a lot to be desired. So you have acute treatments, we have preventive treatments. So acute is something you're going to take as needed, say when the migraine is starting. So classically, it's our NSAIDs like ibuprofen, naproxen. We have the combination products like Excedrin. As these are all available over the counter, and we'll get to some slides later where you can run into trouble with overusing these that can make the headache syndrome worse. The triptans came around in, I believe it was in the 1990s. So Imitrex is the most well-known, that's sumatriptan. There's rizatriptan, there's multiple others. They were a nice addition to the market. They're more specific for migraine. They work by blocking some serotonin receptors in the brain. They have a fair amount of side effects, and some people don't like the effects they get from the triptans. So there was more work that needed to be done. Muscle relaxants at times, if there's a fair amount of neck pain and things contributing, or if they have coexistent tension headaches, they can be of benefit. The new developments have been what's called the G-PANTs. So those are they actually were working on these 20 years ago, and the initial generations of these ran into some liver issues with the first product. So they had to go back to the lab and the drawing board. And it's been within the past 3 or 4 years that we've had these new therapies come out, thankfully with no liver issues. There's one in a class called a diatan, which is in a class all of its own. It also works on serotonin receptors, but different than what the triptans do. And there's also new neurostimulation techniques, devices one can wear that can be really helpful. So those are what we're taking as needed. But what about if someone needs to prevent the headaches because they're having too many? and they're having to rely on the acute medications too frequently. So in the past, the older medications, we would use the anti-epileptics, some old antidepressants, some blood pressure lowering medications. And as you can see, these were medications created for something else that we found as people were taking these, perhaps for those other things, that they had better migraines. So they started to be used in the migraine world. Botox then came along and changed everything. So especially for chronic migraine patients, remarkably effective, really gave hope to people that were struggling with chronic migraine. Next is the MABs that came out. So those are monoclonal antibodies to a target. So those were about 5 or 6 years ago came out. Those have been a really nice addition. There are also the GPANT class, as you saw in the acute side. There's also preventives for that, and also neurostimulation devices. So this is that problem with, it's called medication overuse headache. I deal with it frequently in my clinic, in the headache clinic. As I mentioned, Excedrin, ibuprofen, Tylenol, all those things are over the counter. So patients start taking those, and initially they're helpful, but then they start having to take more and more of it for less return. And what happens is it can make their headaches more challenging to treat. So the official diagnostic criteria is on the side here. So if the patient's having 15 or more headache days a month and they have some pre-existing headache disorder, typically migraine, and they're regularly overusing these medications, and there's a couple of different classes. There's the ergotamines, opioids, triptans, barbiturates. So this combo is like one called Fioricet. If that's taken any more than 10 days per month, that puts you at risk for a medication overuse headache. And then the simple analgesics like ibuprofen, aspirin, things like that, is more than 15 days a month. So when do we start a preventive medication? Well, it's of course a case per case basis. So I'd say kind of a rule of thumb is if we start getting about 5 migraines a month, we start thinking about preventives. But if the patient has 2 attacks, but they're disabling and they're missing work, they're missing events, we might think about prevention then. So they also may have contraindications to using acute medications. Maybe they can't take NSAIDs, they can't take the triptan class because they have heart disease, because those can cause some vasoconstriction. So if they're limited on what they can take from the acute medication standpoint, we may go to prevention earlier. Especially if we notice they're overusing acute medications, we need to get control of that quickly. We need to educate that that's happened, and then we need to start on a preventive medication. So what about imaging? Do I need an MRI for my migraines? Well, I put a couple of images up here, and what I'm showing is 2 completely normal MRIs. So in general, we don't need imaging for migraine. There may be some things, some red flags that we look for. So to determine who we're going to image. So if they have systemic symptoms, meaning they have fevers, weight loss, they have some other risk factors, maybe it has some disorder suppressing their immune system, whether that's infectious or they have a cancer and they're on some immunosuppressant medications, we would be more likely to image. As part of an initial evaluation, we're going to do a neurologic exam. And if we find anything abnormal, we're going to go ahead and image. If we have a sudden onset, abrupt or progressively worsening, that would be another reason. We have something, a thunderclap headache. If that happens, like worst headache of my life, it hits me all of a sudden, that needs to be taken seriously. And that's an emergency department situation, and imaging is done. If we have a patient over the age of 50 and they've never had headaches and we have a new headache that started, we're going to image and we're going to check some lab studies on that patient. Also in patients who have a known history of headache, if something's really different than their previous headaches, then we're going to go ahead and image. Or another thing called a triggered headache. So if they get it with exertion or Valsalva or bearing down, we might want to consider imaging there. So CGRP, this is the big target for migraine. We know this is involved calcitonin gene-related peptide. That's the last time I'll say that. So I'll call it CGRP from now on. But we know this is involved in multiple areas. So the business of migraine actually is happening kind of outside the brain in the meninges. So as you can see, the blow-ups here have a trigeminal nerve and a mast cell. So that's the cell that's going to interact with the trigeminal nerve and release inflammatory substances, and CGRP is involved in that process. And on the bottom left, there's a blood vessel. So one thing that CGRP does is leads to vasodilation of blood vessels, which is an increase in blood flow, which can deliver even more inflammatory substances that can get this process started. So, and also there's nerve-to-nerve transmission of pain. So on the bottom left, we have two trigeminal nerve cells that are communicating with each other, and we know that CGRP is involved in propagating that signal downstream. So it starts outside, then it moves inside. So deep in at the bottom of the brain figure in the brainstem, we see it's kind of a relay station in the brainstem that goes to the thalamus, another relay that then goes to the cortex of the brain. So it's kind of a loop of activity that happens. So if we can intervene and block CGRP early on the periphery, that's what we're doing with these new drugs. So one thing that it does is it prevents that vasodilation, but it doesn't cause vasoconstriction of the arteries. So that's important, as the tryptane class can cause vasoconstriction. So we get worried when people have some vascular risk factors, heart disease, things like that. So the nice thing is we're not seeing any constriction with blocking CGRP. And we can reduce inflammation with that mast cell interaction, and then we can reduce the nerve-to-nerve transmission. So some brave individuals, as part of some of the initial trials, agreed to have their jugular vein monitored for CGRP. So we know that everybody has CGRP, so there's a baseline level. People that have migraine tend to run a bit of a higher level. And then during an attack, we know that CGRP levels rise. And they also found, as part of the early studies, these patients also agreed to have CGRP infused to see if it would trigger a migraine. And in a lot of the cases, it did. So we have CGRP blockers. So we have ligand blockers or receptor blockers. The next slide, I'll get to what's the difference. But the ligand blockers is Ajovy, Emgality, and Vyepti. I will use the trade names because the generics are a bit challenging to say. And then we have our receptor blockers, Aimovig, Nurtec, Qulipta, and Ubrelvy. So a monoclonal antibody versus a GPANT. So an antibody it's a lab-created antibody to a target to block an effect. And the GPANT is a small molecule, like we're familiar with our classic medications we've been on, a small molecule that target to block an effect as well. So basically, what's the difference between a ligand and a receptor blocker? So look at the key and the lock. So the receptor is the lock, and then the ligand is the key. So basically, we're going to block one or the other. We're going to get the effect of lowering our CGRP activity. So they work, some of them work slightly differently, but in the end, we get a very similar effect. So, and in the graphic on the left, that's more of like a virus, for instance, that we have antibodies directed towards. It's going to bind, let's say that's COVID with spike molecules on the surface. Well, they're going to bind that, so that spike molecule can't bind the cells and infect. So we're blocking the activity with the antibody. So how do we decide what to start the patient on? Well, of course, it's a case-by-case approach. So I want to know, first off, is this episodic or chronic migraine? So I have a pretty extensive screening questionnaire when patients come in, and I want to know how many headache days a month they're having, how many of those are moderate to severe, for instance, kind of ones that would put them down where they're going to avoid activity, retreat to that dark and quiet environment. The next big question is, are they overusing medications? And frequently that answer is yes. They're using a lot of Excedrin. Maybe they've gotten the product Fioricet. That's one of the main culprits of this. And they've been on it for a while and it's made them worse, and they get diminishing returns. So we need to address that, educate, and start on prevention. What other comorbidities may they have? It's nice when you can find a medication that will maybe treat a couple of different things. Maybe they're hypertensive and you put them on a beta blocker or a blood pressure medication, and you can treat both with the same pill. The new therapies, of course, haven't compared to each other. They compare to placebo, but we all would like to see them compare to one another. So that may be coming. We're hoping to get involved in one of the trials for that. And unfortunately, the insurance coverage, and living in the real world of insurance, what can we or can't we get approved? What does the insurance prefer? A lot of times we have to jump through some hoops to get to the newer generation medications. So if you need a preventive, a lot of times you're not going to be able to start straight away on Botox. You're going to need to try the older generation medications first. And we give them a trial. If they work, great. But if not, we move on. Or if you have side effects, then we can move on to another therapy. So that brings us to the headache clinic we just opened about 6 months ago. So why a headache clinic? Well, we have a high level of expertise. We have a high case volume. We see headache all day, every day. So we have additional certifications, UCNS certification. There's other added qualifications where you sit for examinations in headache medicine. We're efficient. And we have, we can do urgent treatments. So if someone's, we want to try to keep people out of the emergency department. It's not a great place to get headache care. And one thing we can do is if you're having an attack that you can't break, they can come in for nerve blocks. We can set you up for infusions, things like that. We have access to the newer medications. We get a lot of samples that we can provide for patients. We stay up to date on the developments in the field. So we're going to our scientific meetings, yearly, participating in some clinical research studies. As I mentioned, we hope to get involved in a study that's doing some comparisons between the new products. And we have access to resources such as patient assistance programs. We have a pharmacy employee that's embedded in the practice, and that has been an enormous help for us. She's an expert at getting these medications covered and knows kind of which boxes to check and things we need to do to get the patient on the medication or get them set up to get patient assistance with the companies. So we see really anything headache, but the lion's share of that is migraine. So, but there's cluster headaches. There's something called the TACs, the trigeminal autonomic cephalalgias. There's various under that heading. Those are rare. We see a fair amount of post-concussive or post-traumatic headaches. A lot of times that looks very much like migraine. We do see tension headache. A lot of times it's coexisting. We tend not to see just tension headache alone. Those are usually milder and don't reach medical attention. What's called a cervicogenic headache. So yes, sometimes neck problems, structural neck problems can lead to headaches. And there's also cervical dystonia, which is an abnormal a tightness in the neck that can lead to headaches. So we manage that as well. But it's also a multidisciplinary team. So I mentioned the neck problems with neurosurgery. So, at times there's a lot of neck pain. We'll do a scan and we find there's some significant structural disease. That's what we'll refer to our neurosurgical colleagues for an opinion. We have pain management. So maybe those patients, maybe they don't need surgery, but they need some kind of injection therapy, deeper like epidurals or medial branch blocks, things like that. We can lean on our pain management docs for that. We have the pharmacy employee embedded in the practice, which I mentioned has been very helpful. Physical therapy is very helpful for migraine patients. There's a lot of neck pain in migraine. There's a lot of tension in the shoulders. A lot of people hold tension in the shoulders thanks to a lot of the computer work we have to do nowadays. So I do send a lot to physical therapy. We don't have a psychologist, but psychology can be very helpful. So pain psychologists, those are things you can do online. And of course, radiology, when we do need imaging, we have all the resources available for whatever kind of scan we would want to do. So, what if you're not into the medication approach? Well, there are some natural approaches one can take, and I'm asked, what supplements do we recommend? Magnesium is kind of a mainstay, but there's various forms of magnesium. So magnesium threonate, THREONATE, or it's called Magtine, is the one I tend to recommend. It's a bit more expensive, but it's much better tolerated and has more efficacy. It's also quite good for aura prevention. If aura is prominent in migraine, I definitely put the patient on magnesium. Riboflavin, a simple B vitamin, that one's very cheap. That can be added in, and coenzyme Q10, also a bit more expensive, but it can also add benefit. A lot of times I'll do start one and see how it goes over a few months and then start the other one. You can start all three, but then you're not going to necessarily know which one's helping and doing what. Butterbur's on there. That's got some data. That's an herb. I don't use it as much. In the past, it's had some sourcing and potential liver issues, so I don't tend to recommend that one. But it is being used in migraine prevention. So there's a lot of activity in the device market. So things you can wear that stimulate peripheral nerves. So Cephaly is on the right upper. So that's kind of a sticker that goes kind of in between the eyes on the forehead, and it has both preventive and acute dosing. Spring TMS, that one's kind of came and went, so I don't know if that one's going to come back, but that one was cost issues that we couldn't get patients on that. It was too expensive from the start. GammaCore is another vagal nerve stimulator device. Again, that one's kind of fallen out of favor. It didn't get good coverage. Kind of the new ones on the scene is a Nerivio device, which you see it's the kind of wing-shaped device with the smartphone next to it. So that's a peripheral nerve stimulator, and that will sync with the phone. And it's kind of like a TENS unit that we would use maybe for muscular problems, but it's something that you strap on the arm, you sync to the smartphone, and you increase the intensity. And the idea is that it's sending a new signal to the brain while this kind of neurotransmitter / electrical migraine process is starting. We're sending a new electrical signal to the brain. It's kind of a diversion technique, the way I see it. And then the Neuroleaf device is on the bottom, and we're the only center in this area that has access to this. It's just been launched, and they're kind of in a early rollout. So this stimulates a couple branches of the trigeminal nerve in the front and the occipital nerves through the hair on the back. So this can be used as needed and preventively as well. And there's various ice garments you can wear. There's a thing called TheraIce that can be helpful. So some people like to say apply ice packs and things when they have a migraine. Well, there's companies that will make products that you can wear and maybe keep in the deep freeze. So there's various apps you can use. I usually recommend Migraine Buddy. So that's a smartphone app that you can use to track your headaches, try to find associations. It's a nice way to get objective evidence of how often you're truly getting headaches and migraines. And you can come in and present that data at the clinic follow-up visit, and it can be helpful. Perhaps tracking devices, things you wear that may provide data that's coming in lots of different healthcare areas. So I think stay tuned on that as far as how those might be able to help us in migraine. And that is it. So I will open it up to questions.
Well, that was fascinating, just fascinating. And there's one thing you said during the presentation. You talked about aura. And I've had a lot of people in my practice years talk about having headaches, and they talk about their vision becoming crackly or scratchy or broken glass like. Can you describe for the audience what aura is, what's a typical component of aura, that kind of thing?
Sure. So about 30% of people with migraine have auras. So more don't have aura. So aura is thought to be a wave of electrical activity that propagates through the brain that tends to happen prior to the start of the pain part of the migraine. So usually it's visual, as you mentioned, but it can be other things like numbness and tingling, even stroke-like symptoms where patients can get weakness. What differentiates, say, the weakness of a migraine from that of a stroke is that it evolves with time. So it might start in the face and spread to the arm, spread to the leg, which is not typical for a stroke. So we're looking for something that evolves, and typically the symptoms are what we call positive and not negative. So positive, so for the vision, so shimmering or flashing, things like that. And it tends to evolve across the visual field, or the numbness and tingling is more of a tingling with aura, and with stroke, it's more of an absence of feeling. With stroke, it's absence of vision or complete loss of vision, or it's weakness.
But we have a lot of questions from the audience, and I want to get to those. So first is, do you recommend trigger point therapy?
I do. Yeah, trigger points can be helpful. Like I mentioned, things that we can do in the clinic for patients that are in a bad way, their medications that they're prescribed aren't working. What we'll do is, I mentioned nerve blocks. So we can do occipital nerve blocks. I can do auriculotemporal. I can do supraorbital nerve blocks, supratrochlear. So there's various nerves I can block. There's a thing called a sphenocath we can do, which blocks another part of the trigeminal nerve system through the nose. So it's a flexible tube we use for that. But absolutely, I do add trigger point injections, especially if there's a lot of neck component. So I will do that sometimes along with the blocks, sometimes trigger point injections alone.
So I worked with somebody in the operating room, and they used to have cluster headaches. And they came to me and asked me about the sphenocath procedure. Can you just talk about that? Is this sphenocath for cluster headaches, or is it for migraine headaches?
Really can be used for any type of headache. So it is a kind of a long, flexible tube. And what we do is the patient comes in, and we try to put some numbing medication with a little spray up the nose, some lidocaine.
Mm-hmm.
And then we put some, usually some lidocaine jelly on the tube, and the patient lies on the bed with their head kind of back. So we can make sure the medication, we're hoping that it sits on top of what's called the sphenopalatine ganglions. That's part of the trigeminal nerve system. And so basically, once we get it to the back of the nose, we pull back, and there's a little catheter that deploys at a downward angle, and we just drip in some lidocaine and marcaine.
Mm-hmm.
And then the patient's supposed to stay in that position for about 5 minutes, let it kind of sit there and do its thing. So I see it really as kind of a fire extinguisher. So if you're in a bad way, your medicines aren't working, it's something you can come in and get to knock it out. There's some who've used or tried to use sphenocath at least preventively every couple of weeks. I tried that initially. I didn't find it to be terribly helpful.
Mm-hmm.
So I usually just use it acutely.
Okay, that's great. Well, I'm going to the operating room after we're done and tell this person to look you up.
Okay.
There's a question here about the CGRP images. And I want to tell you, I was fascinated. It was a long time ago when I studied about migraines, and I knew the migraines were caused by what happened in the dura, the covering around the brain. But your explanation of how the fifth cranial nerve, the trigeminal nerve, caused that in the mediation was very important. This particular audience member wants to see that slide 12 again, and we're going to publish this on after the event. So I would encourage that person to look back at slide 12. And then also you might want to look up an anatomy book, because I had to run a little anatomy in my head. But here's a question from the audience. How can I pinpoint what triggers my headache?
Yeah, that can be challenging. So apps like this, Migraine Buddy, can be helpful. I'll say the number one trigger for migraine is stress. Mm-hmm. So if you can limit stress as much as possible, sometimes good luck with that. In women, hormone changes around menses can be really a struggle. Weather changes actually around here is a big factor. Mm-hmm. So, Joe Lorion, I think it's 41. He does a migraine forecast. He must know some people with migraine, or he has it himself, but it is a real thing. Just like arthritis, migraine patients in a way can predict the weather at times. So, then we get into what foods might be triggering my migraines, and you can try different food eliminations and things like that. I find that to be very challenging. One of the reasons is there are phases of migraine, and there's something called the prodrome. So these are symptoms that occur even before the aura would start. It can be up to a day before the migraine even starts. It can be really nonspecific symptoms: fatigue, excessive yawning, strangely, food cravings. So sometimes people, they may have some chocolate because that's a common food craving. They may get a migraine after they've kind of binged on chocolate. But then they notice every time I have chocolate, I don't get a migraine. So how is that? So, well, it may not be a trigger at all. It may just be a food craving that's happening prior to the migraine. Now, these prodromes can be really difficult to pin down because the symptoms are nonspecific, but that, I believe, is what makes it so challenging to find, especially food triggers. We do know that things like MSG, that's a preservative in foods, that's been shown to be a trigger for migraine. Red wine can be a trigger, and other types of alcohol, but in particular, red wine is one. So it can be very challenging, and I'd have to say a lot of my patients don't go on to find any specific trigger besides the ones I mentioned, like stress or hormones or weather.
Here's another question from the audience. Is the neurostimulation that you described in the slides like using a TENS unit?
Sort of. It has some different stimulation patterns, because I've tried all these stimulation devices. So the Neuraleaf device, it goes through different stimulation patterns. So could you take a TENS unit and attach it kind of above the eyes where one of the stimulation points is, get the same benefit? I don't think so. And then the added thing with the Neuraleaf device is it stimulates the occipital nerves, which you've never been able to do externally before. So that's going to stimulate through the hair. You don't have to have my hairstyle for it to work. It'll stimulate through longer hair. So we're kind of getting this dual stimulation of two nerve populations we know is involved in migraine. So we're stimulating the trigeminal, which is involved a lot, but also the occipital cervical system that's feeding into the brainstem. So it's similar, but could you just go buy a cheaper TENS unit and get the same effect? I don't think you could.
Okay. Another question from the audience. This person's on a number of medications. Could any of the medicines that they're taking for other conditions be triggering migraines?
Potentially. So like I mentioned, let's say you have arthritis and you're taking a lot of nonsteroidals or pain medications, that certainly can do it. Maybe someone has chronic pain from another source and they're on maybe opioid medications for that. That can certainly make migraines worse. One of the cardiovascular medications, which would be nitroglycerin, we know can be a potent migraine trigger. So if we see patients that have migraine and maybe they're having cardiovascular issues in the hospital and they get nitroglycerin, which they need, but we kind of expect that they're going to get migraines from that. So another, not a medication, but something a lot of people consume is caffeine. So I'm not an absolutist about caffeine. Some say don't do caffeine at all. I really follow what the American Headache Society says. That's try to limit caffeine to no more than 200 milligrams a day, which is, 3 or 4 cups of coffee. A problem with caffeine, though, is it's more so the withdrawal. So if you do caffeine during the week, say when you're working, and on the weekends you lay off, you might get that rebound headache. So what I tell patients is if you're going to do the caffeine, you need to keep it stable. Do it during the week and on the weekends.
Great. Well, here's a question from the audience. Is there a way to diagnose what foods are a problem? I am celiac sensitive, but other things still give me a problem. You address this as a real difficulty. Is there a way I can figure out without using the FODMAP diet, what is there an allergy test that could be of value?
I think at times, if you have known sensitivities like that, then sure, you could get the advice from, say, an immunologist, and not just for food sensitivities, but other times other allergies can be a trigger for us as well. So, maybe that's either an immunologist or a GI specialist that you could visit with. But it is, it's very challenging with the foods, because let's say you eliminate almost everything, and then what was it? What was the factor? So I tend to recommend patients eliminate one thing at a time if they're going to do that, but it can be annoying and really time consuming to get there. And in the end, you may not find a food trigger.
Okay, last question from the audience. Are there lifestyle changes that could ease or prevent my headaches? And I think this is probably tension headaches, migraine headaches.
Sure. Yeah. I mean, we still encourage an active lifestyle. So of course, if you're having migraine, it's very challenging to exercise. But we still want people to exercise. People with migraine really need schedule. So getting the right amount of sleep, trying to get the same amount of sleep every night if possible. If you have a sleep disorder, it's important to work on that. Sleep apnea, if that's present, that needs to be treated. So we need to focus on sleep. We need to focus on, a healthy diet. What's a healthy diet? Well, basically an anti-Western diet. So more of a Mediterranean style eating, that sort of thing, staying away from fast foods and highly processed foods and sweets, things like that is good to do. But I really strongly encourage both aerobic and resistance exercises more days than not.
That's great. Well, thank you very much, Dr. Kosa. We hope Dr. Kosa's presentation was informative and helpful. Please join us Wednesday, August 31st for our next Lunch and Learn presentation, Beat Foot and Ankle Ailments with Dr. Angela Walker, orthopedic surgeon, as well as a foot and ankle specialist with Orthopedic Surgeons Incorporated. Thank you again for joining us and have a good afternoon.